This lecture is on occupational toxicology. There's a lot of chemicals out there. There are a lot of chemicals in the natural world, and if you want to try to count up how many are out there, it's well over 5 million. If you look at those that are registered in commerce for the United States, it's about 85,000. And if you look at the number of chemicals that we actually have some kind of an occupational exposure limit on, the numbers are pretty small. It's about 700-800, less than 1,000 at any rate. But the point of this is that we have a wide variety of chemicals that we're exposed to, both in the natural world and from industrial sources, and very, very few regulations or recommendations comparatively to help us deal with exposures to those chemicals. So it's important to really understand a little bit about toxicology to help deal with this discrepancy between the number of chemicals that you can be exposed to and the number of chemicals you have recommendations on. So what I wanted to go through with occupational toxicology is, first of all, I want to define toxicology, go through how toxicologists classify different toxic agents, go through some principles of toxicology, and finally the disposition of chemicals, or how chemicals move around the body. Before beginning a definition, I just want to go back to the Paracelsus quote we had last week about poisons. All substances are poisons. There's none which is not a poison. The right dose differentiates a poison and a remedy. And this is one of the central points in toxicology, the dose-response curve that we'll be talking about a little later. But what toxicology does is it is the study of the adverse effects of chemicals on living systems. So it's a cross between biology and chemistry in that you're understanding how living organisms work. You need to know a little bit about the basic biochemistry of a living organism, and then a little bit of chemistry on how those chemicals will affect the living organisms in a hazardous or adverse manner. It's similar to the field of pharmacology, which studies the beneficial effects of chemicals on living organisms, but it studies instead the adverse effects. The main difference between the field of pharmacology and toxicology, by the way, is dose. You can have two people working on the same chemical, and a pharmacologist is going to be looking at the beneficial effects of that chemical, and a toxicologist is going to study what happens when you get too much of it. And a person who's a toxicologist, like me, who has a degree in toxicology and is board certified in toxicology, is an individual specially trained to examine the nature of these adverse effects and to assess the probability of their occurrence. So in toxicology, you understand really how these adverse effects work and how likely they are to happen. Now, as a toxicologist, if you say someone's a toxicologist, there's really a lot of different things that they could be doing as a specialty in toxicology, and I have a few listed here: of descriptive, mechanistic, regulatory, forensic, clinical, environmental, and occupational. A descriptive toxicologist is what most of the people that I went to graduate school with and ended up doing. They work for drug or pharmaceutical companies, agricultural companies, and anytime you put a new chemical into commerce in the United States, it has to go through a safety assessment, and that's what a descriptive toxicologist will do. They'll get all the data on how toxic a chemical is based upon what is in the Code of Federal Regulations, the tests that have to be done. They'll present it to the regulatory agencies like EPA or FDA and get approval for putting the drug into commerce or chemical into commerce agriculturally or something like that. So it's a type of toxicologist that's pretty common, and it's involved in making sure that proper testing is done before a chemical is used. A mechanistic toxicologist is someone you'll typically see in academics, where they're interested in why, how do things work. And if you are a mechanistic toxicologist, what you'll be doing is studying different pathways of trying to understand, okay, why is this particular chemical toxic in this particular exposure situation. A regulatory toxicologist is going to work for a federal or state agency, and they're going to be dealing with establishing levels for safe exposure to certain chemicals. A forensic toxicologist are going to be toxicologists that are involved in the medical legal aspects of toxicology. If there are autopsy cases where a person has some type of drug of abuse or alcohol or something of that manner, a forensic toxicologist will be called in to examine that. A clinical toxicologist would work in a medical setting for the management of overdose patients. An environmental toxicologist will be focused on a lot of effects for flora and fauna of a region for different types of chemical exposures. And I'm going to be mainly talking about occupational toxicologists, people that are interested in safe levels of exposure for working around chemicals. Now, if you classify a toxic agent, there are many ways that you can go about this, and I have a few listed here. First of all, target organ. Most toxicology textbooks are structured on target organ toxicity. You'll have a chapter on toxicants that affect the liver, chemicals that affect the lung, chemicals that affect the nervous system, et cetera, et cetera. It'll be broken into target organ type of an approach. Alternatively, you can have toxic agents classified by use. For example, they could be solvents or they could be pesticides. So how a chemical is used could be a mechanism for classifying the toxic agent. Alternatively, you could have things classified by effects. For example, you could have, does this chemical cause cancer? Does this chemical cause birth defects? That's an effect of the chemical. The next is physical state. And we'll be using this as we get into some areas of toxicology. Is it a gas? Is it a vapor? Is it an aerosol? And each of those may have unique toxicological properties. Most people who practice toxicology will classify by mechanism of action. This is an inhibitor of this particular type of enzyme. And that's kind of the language that toxicologists use among themselves. And finally, we have poisoning potential. And this is the way that the general public tends to classify toxic agents. For example, you could have a range here. This is just an arbitrary range from super toxic to practically non-toxic, where super toxic would be something that a taste or a few drops could be potentially lethal. And what we're looking at in this particular table is a probable oral lethal dose for a 154-pound person, to practically non-toxic, which is more than a quart. And there is a range of these, and some examples might be something that's practically non-toxic, where you could ingest more than a quart. Ethanol. But even though that's practically non-toxic on college campuses every year, you'll have fatalities from people overdosing by more than a quart of alcohol. Alternatively, on the other end, something that's super toxic could be something like cyanide, where just a couple of drops or a few milligrams are potentially lethal. So you have this range, and it's an arbitrary range of poisoning potential. The next aspect of toxicology is the principles of toxicology, on how chemicals get into the body, the effects that they may have, acute and chronic, undesired, what happens if you have more than one chemical or chemical combinations, and the dose-response relationship. The first of these principles is route of entry, and you can get chemicals in your body by different methods, and they each are going to have unique toxicities. You can get chemicals in your body by inhalation. We'll be spending most of the discussion of chemicals in this course on the inhalation of chemicals. If you breathe them, it is a very rapid method of getting chemicals into the bloodstream. The next is skin absorption, and some chemicals that have certain properties can be absorbed through the skin, and therefore can add to the total body burden of chemical that you're going to be exposed to. The next method is ingestion. This is not typical in occupational situations. However, if people use poor housekeeping, if they bring food or drink into an area where chemicals are present, if they don't wash their hands before smoking, they can get chemicals into the mouth and therefore potentially ingest them. And the last is injection. This does not occur that much in an industrial situation, but I have it on here because if you inject the chemical, especially IV, it can get to your bloodstream as rapidly as inhalation. So inhalation and injection are pretty comparable in how rapid they can get a high blood concentration for exposure to a chemical. The next principle is acute versus chronic toxicity, or exposure and toxicity. Acute exposure is defined as a short or limited duration, usually 24 hours or less, and a chronic exposure is something that occurs over a long period of time. Chronic acute effects are effects that are immediate, and chronic effects are those that are long-term. Now, it's important for both exposure situations and for effects to understand how a person will be exposed to a chemical in what time frame, because the same chemical can have a different type of an effect depending on the exposure situation. Let's take alcohol. It's a chemical that most college students are pretty familiar with. Acute exposure has a unique acute effect. What was going to happen immediately after exposure to a large amount of alcohol is that it affects the central nervous system. And that's pretty well known that you're going to be impaired after the exposure to a certain amount of ethanol. So if you went home and you drank a 12-pack of beer, and then went out and drove and you were given a test, you would be considered to be impaired because your central nervous system is not functioning normally. Now, let's fast forward 30 years. You went home and you drank that 6-pack or 12-pack of beer and you liked it and you did it again for the next 30 years. Now what's the long-term effect going to be? What's the chronic effect going to be? It's going to be liver cirrhosis. And so you have the same chemical, but a different exposure situation leading to a different endpoint. And that's common with industrial chemicals as well. In the first lecture I mentioned as an example of a chemical, benzene. And benzene, actually, if you're acutely exposed to benzene, it's like kids sniffing glue. They get high off it. So it also has central nervous system effects for short-term exposure. But if you're exposed to it for long periods of time, the chronic effects are blood disorders, in particular leukemia. So again, the same chemical can have a different endpoint depending upon if the exposure is acute or the exposure is chronic. You can also have undesired effects from many chemicals. For example, you could have allergic reactions, delayed, immediate effects versus delayed, reversible versus irreversible, local versus systemic, and an allergic reaction requires an immune component. And with an allergic reaction, you're firstly exposed to the chemical, you develop antibodies against that chemical, so the next time you're exposed, you'll have a reaction to that chemical. And this can range from anything from a mild skin rash to something that could be life-threatening, like an asthmatic reaction, like you might see with some of the isocyanates. So allergic reactions do happen to a lot of chemical, particularly for skin type of allergies. An immediate effect of a chemical is going to be something that happens right at exposure time. If you spill acid on your skin, you'll get an acid burn. If you are exposed to benzene or vinyl chloride or something like that, your delayed effects are going to be some cancers that may develop over years, or if you inhale different types of dust, you might get delayed effects of different pneumoconioses, diseases of the lungs. A reversible versus irreversible, again, if you spill the acid on the skin, your skin will heal. You're going to get better, and many chemical exposures are going to be reversible. You have some acute injury, but you recover from it. An irreversible effect is going to be something that you can't recover from, like cirrhosis of the liver is an irreversible effect. Developing benzene-induced leukemia is an irreversible effect, etc. And then local versus systemic. Now, a local effect occurs at the site of contact, wherever you're exposed to the chemical. It gets on your skin, it's an acid, you get an acid burn at the site of the skin. A systemic effect is something that we're going to be talking about for most of the chemicals in this course. They are chemicals that you are exposed to by one route, and they penetrate the tissue barrier and get into the blood and have effects elsewhere. Like alcohol, you drink it, but it's going to affect your central nervous system, or chronically it's going to affect your liver. Like benzene, you breathe it, it's going to affect either your central nervous system or cause leukemia. The next area on chemicals is chemical combinations. And typically, you're not just exposed to one chemical, you're exposed to more than one chemical. And chemicals do interact with each other. Unfortunately, studying the interactions is pretty complicated, and you typically just have an exposure limit for one specific chemical. And many times you're going to have a multiplicity of chemicals that you could have exposure to. And there are interactions that can occur with chemicals, and I have two listed here, additive and synergistic. I'll start with additive on the bottom first. If you have typically solvents, if you have one solvent that has maybe a central nervous system effect and you add a second one like benzene and toluene, the effects are going to be additive. They're very similar and they follow the same pathways, so you'll have an effect of 1 + 1 = 2. And ACGIH actually has some methods of coming up with an exposure limit when people are exposed to a variety of very similar chemicals, in particular solvents. So there are methods of establishing recommendations for additive chemicals. Synergistics are much more complicated. You'll see these in the pharmaceutical world where drugs and alcohol don't mix because they follow mechanisms that amplify the adverse effects of one of the two exposures. And that can happen in the occupational world as well. A well-known example is the effect of cigarette smoking and asbestos exposure. If you have exposure to asbestos, you have a relative risk of developing lung cancer that's one number. If you're a smoker, you have a relative risk of developing lung cancer that's another number. If you smoke and are exposed to asbestos, your relative risk of developing lung cancer skyrockets, and that's due to synergism. So a synergistic effect is like 1 + 2 = 20, where the combined effects of the two exposures are much worse than the effect of each individual exposure, and they do occur with many different chemicals. The next area is the dose-response relationship, and this gets back to what Paracelsus said, the dose makes the poison. But it's defined as the relationship between the degree of exposure, i.e. the dose, and the magnitude of the effect, the response. Now this is a typical dose-response relationship. This has percent mortality on the y-axis and dose on the x-axis. And what you're looking for percent mortality is as the dose gets higher, more and more of whatever's being studied dies. So you have at about 100 milligrams per kilogram here where I have the arrow, is about 50% mortality. So what you see with this is a population, low doses, some are going to be susceptible. At mid-range doses, most are going to be susceptible, and at very, very high doses, eventually everybody's susceptible. And this is typical with a lot of toxicological relationships. It's typically not mortality. It could be many different types of parameters that are being studied, inhibition of liver enzymes or lung inflammatory responses. Could be anything that you're measuring, and the higher the dose, the more you're going to see a response. And in addition to that, at the very low doses, you're going to see certain people that are very susceptible, and at the high doses, you're going to find people that are very resistant. But eventually, with most chemicals, everybody is going to be affected by it if the dose gets high enough. And again, this is a typical dose-response relationship. Now you can get some information out of this, and if you are in the regulatory toxicology business, you look at dose-response curves a lot, and you base your exposure limits to people based upon what you see in a dose-response curve. You really are looking at two areas, the NOEL, which is the no observed effect level. It's the highest dose in an experiment which did not produce an observable effect, or the LOEL, which is the lowest observed effect level, i.e. the lowest dose, which produced an observable effect. And if we go back to here, we have a little circle. And this little circle is the region where you're going to be looking at your NOELs or LOELs. This is your low effect level. And usually your risk assessment process starts at this point. You are going to want to make sure that workers or people in the environment are not going to have an adverse effect from chemical exposure. So you see what happened when you studied animals, and you find that this is the lowest level where anything occurred, or below which nothing occurred, and then you establish safety factors from this point on. Now, if you do a lot of dose-response curves, you'll see variability in the dose-response curves, even among the same species being studied. If you have genetically identical rats or mice, you'll see differences in the dose-response relationship. And it's pretty common you will see interspecies variation. It's much wider when you're studying people. And if you have two people that are working side by side and have the same chemical exposure, one of them may get sick and one of them won't. And there are reasons for that. The same with lifestyle influences. If you have two people that are smokers, one person may develop disease and one person won't. Well, why is that? Well, there's a lot of reasons why you'll see interspecies variation. Age. So older workers may be more susceptible to the effects of some chemical than younger workers. Gender and hormonal status. Men and women may respond differently to different chemical exposures. Genetic makeup. are going to be really, really important depending upon how you metabolize certain chemicals and your general state of health. If you already have some kind of pre-existing respiratory condition, if you're exposed to a respiratory irritant, you're probably going to have more of a response than a healthy individual. So there are reasons why people are different, and therefore they're going to respond differently to chemical exposures. Now, the LD50 is something that's derived from a lot of dose-response curves, and it's important in toxicology. You want to know the mean, or where about 50% of animals or any subjects will respond to a certain chemical. This is LD50 for it. That stands for death, but you can get 50% responses for other endpoints other than death. But they tend to be used a lot as a comparative purposes for different types of chemicals. And this is a graph of LD50 for many different types of agents. And looking at the top, we have ethyl alcohol, which again we know is poisonous, but it has a reasonably high LD50, so it takes a lot of ethanol to kill you compared to other chemicals on this list. But you go down to the bottom, where you have one of the most toxic substances known to man, our botulism toxin. And you see the differences on that. You have 4 zeros for ethyl alcohol and 1, 2, 3, 4, 5. So it's a 10 to the 9th difference in poisoning potential between the exposure to botulism and to ethyl alcohol. But both of them can get doses high enough that can become lethal. But this LD50 is a useful term to compare the potency of many different chemicals. And again, this is just an example of some common chemicals, most of which on this list you've probably heard of: strychnine, botulism, nicotine, caffeine, aspirin, salt, sodium chloride, ethyl alcohol, etc. And this gives you a relative comparison of their potency. The next area in toxicological principles is the disposition of chemicals. And there are 4 steps in the disposition of chemicals: uptake, distribution, biotransformation, and elimination. Uptake is absorption, how the chemical gets inside of your body; distribution, how it's moved around, transported; biotransformation, how it's changed; and elimination, how it's excreted. And this is a busy slide that basically shows how all these things interact. Up on the top are listed ingestion, inhalation, intravenous, intraperitoneal, subcutaneous, etc. And these are all ways of chemicals being able to get inside of your body. Once they're inside of your body, they're moved around. They go through your blood system, and they can move around to a lot of different types of organs. Some will have different affinity to organs depending upon the blood flow, the chemical makeup, organ makeup, etc. Some will be changed by the process of metabolism, and eventually most chemicals you get rid of, and there's only some limited ways things can get out of your body, which are down here on the bottom: feces, urine, expired air, or certain types of secretions. But this disposition of chemicals kind of puts it all together in this slide. Now, how do you get chemicals inside of your body? How are they absorbed? Well, inhalation is typical for most occupational exposures, and that's going to be a gas, a vapor, or an aerosol. Alternatively, you can get things that absorb through your skin. If the ACGIH booklet has a skin designation, and we'll talk about what that means next week when we get into occupational exposure limits, that means that this chemical can potentially be absorbed through the skin. And a lot of substances that are lipophilic, lipo meaning fat, philic meaning love, fat-loving substances, like tetraethyl lead or organophosphate insecticides, they can be readily absorbed through the skin. And so absorption of chemicals can occur dermally. Transport of chemicals, this is moving chemicals around in your body. They could bind to proteins in your blood, and where they go is going to depend upon the chemical reaching the target organ. This is going to vary on affinity of that chemical for the target organ, the blood flow through that organ or perfusion, how long they may be stored in that organ, and there are certain barriers in your body, like the blood-brain barrier, that make it more difficult for certain chemicals to traverse that barrier than there may be for other organ barriers. And biotransformation of chemicals. I've got about 2 slides on this. In graduate school, I spent about 2 years studying it. It's very important. Every chemical you're exposed to, it's not a metal, it's going to be transformed. And biotransformation is a way of trying to make a chemical more water-soluble so that it can be excreted through the urine. So it's a process of chemical conversion. It usually makes something less toxic, and it makes it so that it can be combined with another chemical that is easier to excrete within the urine. This is the kind of the process by which it works. You have a nonpolar toxicant, and this could be any type of a chemical that's not a metal. It will bind on an enzyme. You get a complex, and it'll throw out something that's more polar. And ROH is a polar metabolite. Remember, HOH is water. So anything that's more like HOH is going to be readily more excretable in the urine than something that's like an RH. So the more water-like it becomes, the more readily it can be excreted via the urine. And this is a excuse me, I just want to spend one more second on biotransformation. This is really important. If you were to be exposed to something like benzene, and an hour later we were to have you give a urine sample, we would probably find 100 different chemicals in your urine that are related to benzene, but not exactly benzene. And this is, again, very common with most organic chemicals. Your body tries to change them into something less toxic and more water-soluble. And unfortunately, it's not perfect, that sometimes the metabolites of the parent chemical are themselves more dangerous. And this is why vinyl chloride is a carcinogen, benzene is a carcinogen. It's not the chemical itself. It's the fact that during biotransformation, it can be changed into something much more dangerous. So this, if you ever take toxicology, this is an important part of toxicology, how chemicals are changed in your body. And then elimination. You just have a couple ways of eliminating chemicals. Biliary, major routes of elimination are through the liver, biliary excretion, which will then go through the feces. The renal excretion is a major route. Most organics are going to be excreted via the renal, especially if they've gone through the process of metabolism to become more water soluble. And you have minor routes of elimination, such as exhalation of expired air, which you'll find with something like alcohol, for example. You can measure that on the breath. Milk, sweat, saliva, hair, and nails are also means of getting rid of chemicals. Now, the last part of this toxicology, before getting into some medical and biomedical monitoring, is examples of specific toxicants. I just want to go through a couple of systems and tell about some typical toxicants that may be occur and affect these systems. The first, we'll start with the respiratory system. In the respiratory system, you can have it affected in several ways. First of all, you can have sensory irritants, and we have a trigeminal nerve, and if you've ever been exposed to hot peppers, if you like to eat hot food, your eyes will water and your face will turn red and your throat will burn. That's from the stimulation of your trigeminal nerve, and a lot of different chemicals can stimulate the trigeminal nerve and lead to upper respiratory issues. Mace, which it's a specific chemical. It's got a long name, but it's something that's used in police spray with pepper spray, which is the next one, capsaicin. They stimulate the trigeminal nerve. But other industrial chemicals like formaldehyde or TDI, which is toluene diisocyanate, can do this as well, and these will cause a burning of your throat and your eyes, and etc. So that's from sensory nerve stimulation. Then you can have irritants that affect the upper respiratory tract specifically, or the lower respiratory tract. And something like ammonia or hydrochloric acid, if you're exposed to any of those, you're going to get a burning in the upper throat, and this is because your respiratory tract is very, very filled with water. It has a lot of water lining it, very moist. And things that are water-soluble, like ammonia and hydrochloric acid, are going to dissolve in the water of the lining of your respiratory tract, and it's going to burn. And upper respiratory irritants, while unpleasant, as long as you have a means of getting away from the exposure, you'll usually be okay. It usually can be a reversible type of an effect. Dangerous, but reversible. Now, the lower respiratory irritants are a little bit different. These things are extremely hazardous, because what happens with exposure to chemicals like phosgene, ozone, hydrogen sulfide, they have very limited water solubility, but they're very reactive. So when you breathe them in, they're not going to dissolve in the lining of your respiratory tract. They're going to make it all the way down to the lower regions of your lung. This is where the linings are extremely thin in your air sacs, and what will happen is that they are reactive enough to actually dissolve or plug holes in the membrane that stands between your lungs and your blood. So they can cause a condition called pulmonary edema, which is your lung basically will fill up with fluid and you'll suffocate. So these chemicals are extremely hazardous in high concentrations, phosgene, ozone, hydrogen sulfide, due to their ability to create pulmonary edema, which is a life-threatening condition. Now, some other respiratory system toxicants, things that cause diseases. They can be obstructive, restrictive, or cancer. Obstructive diseases are those which kind of have plugging up of the airways, like asthma. Restrictive diseases are when your lungs become filled with scar tissue from exposure over years to things like silica, and you can't breathe in and out very readily anymore. And cancer, of course. And most of your restrictive diseases are going to be caused by inhalation of dust. And when you have inhalation of dust, the term for that is a pneumoconiosis. And depending upon the kind of dust you have, it's going to have a pneumoconiosis name. Like if you inhale asbestos, the disease is going to be asbestosis. If you inhale coal dust, it's going to be coal workers' pneumoconiosis. If you inhale silica, it's going to be silicosis. And the problem is you have, and we'll talk about this in a couple of weeks when we get into more on aerosol and aerosol toxicity, is that you have limited ways of clearing this material out of the air sacs of your lung. And one way you do that is you have some inflammatory cells that respond to the presence of dust in the lungs. And when they do this, they try to engulf the dust particle and ingest it so that it can go away. But when you have some of these dust particles, like silica, for example, it can actually puncture these inflammatory cells, and the enzymes that are supposed to be dissolving the particulate matter actually leak out and dissolve a little bit of your lung. And when that occurs, your lung will repair itself, but it will repair itself with scar tissue. And if this goes on for years and years and years, and again, many of these diseases are chronic, you'll have exposure, goes on for years, your lungs ultimately become a mass of scar tissue. And scar tissue doesn't expand and contract very, very readily, and so a person cannot meet their oxygen demands, and therefore these restricted diseases that are listed here are very, very serious. In addition, some chemical exposures can cause lung cancer. The most common is from tobacco smoking, but other chemicals can do this as well, like asbestos, hexavalent chromium, and the most potent lung cancer-causing agent known, bis-chloromethyl ether, which has the distinction of being the only chemical that OSHA has set an exposure limit of 0 to. If you work with this chemical, because of its potency for causing lung cancer, it has to be in an enclosed and isolated system. The next area I wanted to discuss are circulatory system toxicants, and primarily asphyxiants. These can be simple or chemical asphyxiants. And this is an important class of chemicals as well. A simple asphyxiant means that there's just not enough oxygen present, and this chemical has displaced oxygen from the environment, so you suffocate. Like argon, methane, acetylene, if you get into an atmosphere where there's no oxygen, but there's these other chemicals, you're going to succumb to simple asphyxiation. I even have carbon dioxide listed here because there have been cases of people who have died from carbon dioxide poisoning when there was inadequate oxygen in the atmosphere. The lower list is chemical-specific asphyxiation, and these are a little bit more commonly known, and I have some of these chemicals down here. And if you were to ask me as a toxicologist, what the chemical that scares me the most is, of any chemical in the world, one of them's on this list, and that's carbon monoxide. Carbon monoxide is an extremely dangerous chemical, and it's led to a loss of life in many, many cases. If you have inadequate ventilation and a flame source, you can produce carbon monoxide, and it is a chemical asphyxiant, because what it does is preferentially bind carbon monoxide to hemoglobin as opposed to oxygen. So with carbon monoxide poisoning, you tend to have oxygen in the air, but if there's carbon monoxide present, it will take up the binding sites of hemoglobin so that there's no oxygen in the blood that can be transported into the tissues. And it it binds much more readily than oxygen does, so it really takes pretty low levels of carbon monoxide to fill up the hemoglobin binding sites, and so you can't transport any oxygen to the tissues. The other three, hydrogen cyanide, the other two, hydrogen cyanide and hydrogen sulfide, are pretty similar, but with those, they bind the ability to unload oxygen into the cells. So with cyanide and hydrogen sulfide, there can be plenty of oxygen present in the air. Your blood can have plenty of oxygen in the hemoglobin, but it can't unload it because it's blocked on getting oxygen to the tissues. So they can be acutely lethal from those. Methylene chloride, which is listed there, is a little bit more interesting in terms of toxicology, in that it's a chemical that's metabolized within your body to carbon monoxide. So if you are exposed to high levels of methylene chloride, it can be metabolized and create inside of your body carbon monoxide, which can then bind your hemoglobin and cause a toxicity. Methylene chloride is commonly used as a paint stripper, and so if you're using a paint stripper in high concentrations in an unventilated area, you can have a significant enough buildup, and there have been many documented cases of people using paint strippers that contain high levels of methylene chloride succumbing to the effects of carbon monoxide from internal metabolism. The next system is the kidney, and the kidney is filters and gets rid of excess water and solutes from the blood and forms urine. And renal excretion is the major mechanism for eliminating excess water, metabolic waste products, and metabolites. Toxic substances can accumulate in the liver and kidney and cause damage. For example, many metals like arsenic, cadmium, lead, and mercury are notorious kidney toxicants. Some nonmetals like carbon tetrachloride or ethylene glycol, which you're going to find in antifreeze, are also very poisonous to the kidney. The next system is nervous system toxicity, and the nervous system is going to be composed of either your central nervous system, which is your brain and spinal cord, or your peripheral nervous system, which is nerves to the glands and muscles. And nerve transmission is somewhat complicated and involves both electrical and chemical systems, and both of these pathways can be interfered with by a variety of toxicants. The neurotransmitter interference, a lot of the bizarre toxins that you've heard of from snake, scorpion venoms, and etc., tend to interfere with electrical transmission on the nerves, and so it can be a real problem with exposure to some of those substances. The organophosphates, which are used for pretty commonly in pesticides, also are interfere with neurotransmitters. They interfere with the space between one nerve and the next, where chemical transmission is sent on to the next nerve to tell your muscles or your glands to do something. And as an extreme example of this, a lot of your organophosphates are used in nerve agents. VX, sarin, etc. are very potent organophosphates, much more potent than you use around the garden, but the mechanism is exactly the same. What they will do is interfere with the neurotransmitter acetylcholine, and they interfere with it in such a manner that the effects of acetylcholine are amplified. And so these effects, when amplified, can be very, very serious. Other chemicals can affect the central nervous system. Many solvents, like I mentioned earlier, benzene, can lead into a euphoric type of an effect. Carbon monoxide also can get into the brain. Lead, manganese, mercury, all chemicals that are well known for their effects on the central nervous system. And some chemicals can cause peripheral neuropathy. This is a type of condition that's caused by the myelin sheath of the long nerves being broken down. So it's kind of like the insulation on a wire being worn out, and so that it short circuits what the nerve is supposed to be doing. This can lead to muscle weakness, numbness in the hands and feet, and chemicals like lead, carbon disulfide are known to do this, as well as hexane, which is metabolized to a metabolite called 2,5-hexane-dione, which also leads to demyelination. I'm going to have a couple more chemicals here just to give you some examples. I call them the gens, carcinogens, mutagens, teratogens. Things that cause cancer are carcinogens like coal tar, arsenic, hexavalent chromium, benzene, vinyl chloride, bischloromethyl ether, which I mentioned in a few slides earlier. Mutagens, these are things that affect the genetic material, or teratogens. Teratogens cause birth defects. Something like lead, mercury, PCBs are all known to cause birth defects. I want to switch gears a little bit here and talk about biological monitoring. And what biological monitoring is it's the assessment of an overall exposure to a chemical through measurement of the chemical or its metabolites in biological specimens. And this is another definition I want you to know. And I want to make sure in your definition that you include the words or its metabolites, because that's a real important component of the definition of biological monitoring. ACGIH has developed biological monitoring years ago, and they call them BEIs. These are biological exposure indices, and they have them for over 50 chemicals. And as long as you know the disposition of chemicals, i.e. the absorption, distribution, metabolism, and elimination, you can come up with a reasonable biological exposure index for any type of a chemical. And this can be useful because it can help supplement air monitoring. It will average exposures over long periods of time, and it can help you test for cumulative hazards, things that are building up in the bloodstream or other tissues. And it can assess the control effectiveness that you have in place. If you have people wearing respirators, or you put in a new ventilation system, or you've done new work practices, and you still are seeing chemicals that tell inside of a body from a blood or urine sample or something, that tells you your controls aren't working properly. So it can supplement what you're doing with your air monitoring program. There might not work out completely well with your air monitoring. There may be some inconsistencies based upon the workforce makeup, how the work habits are. If somebody breathes through their mouth or nose, you're going to get a higher concentration of chemical, environmental conditions, or some other exposure routes that may occur, things that they're doing off the job, for example, or you may be getting chemicals in from ingestion or skin absorption. But what are you measuring for with biological monitoring? Well, you have a couple of choices. You can measure for the chemical itself. For example, lead in blood. You can do a blood sample and measure for lead. Alternatively, you can measure for a metabolite of some exposure. Carbon monoxide, the metabolite is going to be carboxyhemoglobin, and that can be measured in the laboratory. If you're exposed to benzene, euconic acid, which is a derivative of benzene caused by metabolism of benzene, will be present in urine, and you can measure that. So that would be a method of biological monitoring. Or in some cases, like for organophosphate pesticides, it's very difficult to measure the levels that cause problems in vivo, inside the body. So you will pick a reversible biochemical change, like an enzyme that they inhibit, and these particular pesticides will inhibit the enzyme cholinesterase, and you can measure the amount of cholinesterase inhibition as a way of biological monitoring. So there's different strategies that can be used for biological monitoring. Now, what biological specimens? Well, you're limited. You can use blood, and blood would be used for some things like metals, or urine could be used for metals and organic metabolites. Exhaled air could be used for carbon monoxide or solvents such as ethanol. And you could use other biological specimens. You could use metals in hair, or fat-like substances in fat, like dioxins or PCBs or EDT. And lead may accumulate in bone or teeth, and these could be measures of exposure. Now, biological monitoring isn't perfect. There are some problems with it. First of all, it's an invasive technique. You're going to have to take a blood or a urine sample from someone, and so that could be that is invasive. Timing is really important. Some chemicals are metabolized rapidly. Many solvents. We'll use ethanol as an example. If you consume, let's say at 8 o'clock in the morning, you consume a drink of alcohol, and if you have biological monitoring via urine, blood test, or whatever, blood test or exhaled air at 5 o'clock, it's going to be completely gone by then. So the timing of the test has to be set up that's consistent with what you know about how the chemical behaves inside of a body. And then there's privacy issues. If you are giving a blood sample or a urine sample for to look for a specific chemical, it could pick up other chemicals, and so this has to be handled very carefully to make sure that the information that's obtained from the test is used properly. The last area of this lecture is medical monitoring. And medical monitoring is similar to biological monitoring, but it's not measuring the presence or absence of a chemical. It's doing the following. And again, this is another definition I want you to know. What medical monitoring does is it's an assessment of exposure to a chemical through measurement of a permanent or semi-permanent body change. So you're not measuring the chemical level, you're measuring what the chemical actually is doing. Examples of this, lung function, if you're exposed to a chemical like cotton dust, and this is one of the early OSHA standards, so that's why I'm using it as an example. It affects lung function, and you can measure lung function by spirometry, how much air your lungs can hold and how quickly you're able to expel that air. That's something that can be assessed, and chemicals like cotton dust can affect that. You could medical monitoring as an x-ray. If you do a chest x-ray of someone and you see plaque buildup that's consistent with asbestos or silica, you can assess that. I have dibromochloroPropane here. It's another medical monitoring for sperm count. And this was kind of a famous medical monitoring problem in that years ago, people working in a pesticide plant, many of the workers were trying to start families and were unable to, and many of the wives of husbands that were working in the plant started talking to each other, and they were finding out that many who wanted to start a family weren't able to, so they went to the company nurse and they started testing some of the men for sperm count, which is not a normal medical test, and found that everybody that worked in this pesticide plant where they produced the pesticide, it's a fumigant actually, called dibromochloroPropane, they were sterile. And subsequently they found out that it was the most potent male sterilizant known. Now the reason I'm bringing this up is it was used and marketed, and there was no indication that this chemical had any toxicity whatsoever until people started talking. And so as a safety professional or as an industrial hygienist, you have to understand that we don't know everything about chemicals, and sometimes you have to listen to people and find out that they may have symptoms that you don't know about. And this is one where it was identified by people talking to each other and finding out, unfortunately too late, that this was a potent male sterilizant. Now there are problems with medical monitoring as well as biological monitoring. Some of the problems with medical monitoring are timing, again, that if you're testing for asthma, for example, by a lung function test, unless the asthmatic reaction is occurring, you're not going to pick it up. The second is cost. These tests can be expensive because they need to be performed by qualified medical personnel, so they can be extremely expensive. And then the third is interpretation. What are normal values? And so many of these, like lung function or hearing or other things, it's important to get baseline values because you do see a lot of individual variability among people that are unaffected by chemicals. And so if you get a baseline, then you can start tracking if any changes are occurring. And that's it.